And I would like to invite them to introduce themselves. I would like to start with the lady. Welcome to the show.
Thank you. How are you, viewers? My name is Margaret Keige from Cancer Awareness Center of Kenya. As the name suggests, we do cancer awareness, and also we do screening, we do patient support, and we have something called support groups. Support groups is where we bring people who are going through treatment together so that we can help them navigate the difficult journey of cancer. Screening is just getting tested, and awareness and advocacy is what like what we are doing this session, to just educate members of the public on the importance and the need to deal with cancer. Thank you very much.
Okay, thanks Lucy for having me in the show. Hello viewers. My name is Ben Bello Onyino. I'm an oncology nurse by profession. I work in KNH or Kenyatta National Hospital, adult cancer ward. In my ward, we normally deal with the patients who come in for chemotherapy, radiotherapy, and also who come just for nursing care who are very sick. Those are the kinds of clients we handle. In our department, we handle all forms of cancers, like cancer of the prostate, cancer of the lung, cancer of the breast. And those are mostly the cases we get in our department or in Kenyatta National Hospital.
Wow.
Thank you.
Thank you so much. We are able to understand that we have professionals in the house. And I would like our clinician, who is Ben, to introduce us to lung cancer. What is a lung? Which is this organ that we are talking about? Welcome.
That's a nice question, Lucy. Thanks for that. If I start by describing the lung. The lung is an organ that's found in the thoracic cavity or the chest cavity. There are two in both sides of the chest. If I might go into details, the right side has 3 lobes and the left side has 2 lobes. In description, I believe when we are doing the biology in primary school science, we know the shape of the lungs and also their location. If I may talk about cancer of the lung, just to start by saying cancer is a disease which affects the cells.
Yes.
But now when you talk about the cells, now we are talking about the cells in the lungs. So the cells, they become abnormal and they grow very fast. So cancer of the lung, this is a disease that affects the cells in the lungs, and thus it's characterized by rapid multiplication of these cells in the lungs. If I may now go further to describe cancer of the lung, there are the 3 main types of cancers of the lungs, but mostly we have 2 which are so dominant. We have the small cell lung cancer and non-small cell lung cancer. Now to bring it more closer, you find there's a type of cancer that's more common among the smokers than small cell lung cancer, so common among the smokers as compared to non-small cell lung cancer. Also, now if I may go to talk about the signs and symptoms of cancer, of lung cancer, there are various signs. And you find in most cancers, the signs and symptoms, they present just like any other disease.
Okay.
Like in lung cancer now, if I may talk about it, you have cough that gets worse or doesn't stop. We have cough, you have sputum that's blood stained, or may say it's rust stained. Also, we have what you call difficulty in breathing, which may come later on as the tumor continues to progress. We have what you may say chest pain, which may come when somebody is talking or laughing or crying, and the chest pain may mostly manifest during that time. Also, we have general body malaise. This patient continues to go with becoming weaker and weaker. Then also we have weakness of the body. So mostly when somebody presents with such a history of cough that's so persistent and doesn't go off, you have tested for TB, it's negative, you have tested for all other chest conditions, and you find out that none of them is manifesting, you should now begin to think about, am I dealing with the cancer of the lungs? Now, if I talk about the causes, the cause of cancer, up to now, most cancers is still unknown. But we have what we normally say, the risk factors or the predisposing factor to cancers. So in cancer of the lung, the predisposing factors, we have like cigarette smoking. Also, there is what we normally call passive, or is it passive smoking, whereby maybe your partner is smoking cigarette. So you have what we call the second inhalation of the smoke. It can also predispose you to lung cancer. Also, we have what we call exposure to asbestos, which is this material that has been used in construction
of the houses.
Yes, but right now it's being worn out of the market. Also, we have exposure to carcinogens like pesticides, insecticides. They're also being associated with lung cancer. Also, we have genetic family history. There's a history of cancer in the family. Maybe especially the first degree. First degree, I mean father, mother, sister. If there's a positive history of lung cancer in the family, the risks are also very high in somebody developing lung cancer.
Okay, thank you so much, Ben. That was a very detailed description of what lung cancer is. And something that caught my ear very closely was about the smoking, secondary smoker. So does it mean that we are all predisposed? Because many other, if you ask even a child, what is the smell of a cigarette, they know, which means it has ever been in our nose. Are we all predisposed?
We are all predisposed because that's why you find the government now came up with policies of setting aside smoking zones areas.
Smoking zones.
Yeah, and also by introducing some bans of smoking in public. But still you find these smokers, there are relatives, there are spouses, there are brothers. So we stay with them in the same house. So if they're smoking in your environment, they're also exposing you, they're increasing the chance of you inhaling the secondary smoke or passive smoke. That's increasing the risk of you developing lung cancer.
Thank you so much, Ben. When we come back to you, we'll be telling, we are in difficult times. COVID-19 is here with us. Tuberculosis is here with us. Then how can we be sure that whatever we have is lung cancer and not all that? I am sure you'll be able to explain that to us. To our Margaret, I love your T-shirt. You look stunning. You're really advertising your company.
Thank you.
Yes. Is cancer really a problem to men?
Thank you, Lucy, and also thank you, Ben, for the great insight about lung cancer. I would like our viewers to take note of the fact that cancer in Kenya is real and the whole world. In fact, worldwide, cancer generally is number 3 killer after cardiovascular diseases and infectious diseases. So we cannot ignore the fact that cancer is here with us, and it is for us now to find ways of managing it and dealing with it. For us in our organization, we call ourselves the social doctors. We tell you what the doctor didn't tell you.
Okay.
For example,
social doctors.
Yes.
Wow.
We will tell you how can you prevent yourself from getting cancer. You've heard the doctor talking about smoking. You've heard the doctor talking about environment. So for us, we try to start with those who don't have cancer as yet. How can we prevent having cancer? So let us be reminded, let all the viewers be reminded that the factors the doctor is talking about, where we can, let us avoid them. Let us avoid smoking directly. Let us avoid exposing our families to smoke and environmental hazards.
Yes.
Nowadays, even when we are growing crops, we are encouraged to go organic so that we minimize the dangers that come with fertilizers and pesticides and chemicals. Then, of course, let us avoid stress. And most important, you are what you eat. Because although there has not been a lot of research and authenticity about the causes of cancer, we are told that 30% of who we are has to do with food, what we put in our bodies.
Yes.
So if we could look at what we eat, healthy lifestyles, we would already be 30% away from all non-communicable diseases.
Yes.
That is
and
cancer.
Is one of them.
Yes, and cancer is one of them. So yes, cancer is a big burden, The other challenge in Kenya especially is that because of late diagnosis, many people experience the symptoms that doctor is talking about, but we do nothing about it. We don't go to hospital. We go to the chemist and buy painkillers, and the disease prolongs. By the time we are going to hospital, it is already stage 3, stage 4. It becomes expensive to manage, and it becomes a big burden to the family. So the cancer burden in Kenya is huge because of late diagnosis and sometimes not taking the health seriously.
Okay. So thank you, Margaret. So this is a clear indication that there is need for people to be made aware
Yes.
about lung cancer, among other cancers, that smoking contributes to a greater percentage of the cancers. We have seen young boys in school, primary school, secondary school, smoking. We have seen women smoking, pregnant and non-pregnant. I'm sure you will be telling us about them because we have a generation that is coming. We have our children who need to understand these dangers. So back to Ben. How do you know that this is cancer, this is not COVID-19? You work in Kenyatta, one of the largest or biggest hospital in Eastern and Central Africa here. You can confirm that one to us. And how has it related to COVID-19? Have you lost most of your patients because COVID-19 has come? We've seen patients who are diabetic or who have issues with their blood sugar levels go very fast with COVID-19. Has it been the same with cancer?
Nice question, Lucy. What I can talk about COVID-19 and cancer, yes, I've seen most of my patients having COVID-19, also cancer. You remember the mortality is very, or they normally talk about the secondary diseases like diabetes, cancer, as being one of the diseases that can increase the mortality of COVID-19. So yes, we have patients who develop COVID-19 right now, and we have seen them. Some have come out of it and gotten healed of it, and some have succumbed to it. So it's real. COVID-19 is here with us, and we should take the precautions that the government has put in place, sanitization, distancing, avoiding crowds, putting on a mask, to reduce the chances of us or our patients, especially in cancer department, because their immunity already has been compromised due to cancer. So now if you bring in COVID-19, the outcome is more grave as you compare it to a person who has no any comorbidity disease.
Okay. Clarify to us, how are we going to say it is cancer and not COVID-19 and not TB?
When you talk about cancer of the lungs, the signs and symptoms that I've mentioned earlier, you find they present more of any other lung, what I can say, respiratory tract infection. The TB, the pneumonia, we have the difficulty in breathing, we have coughing of blood, of which you find in most respiratory tract infections. But still, when a client presents with the above, and history has been going on for long, then maybe you have done tests for TB, and it's negative. You have done chest X-ray, there are no signs of pneumonia. So another thing that you should now begin to think, and we normally encourage or sensitize most health workers in the counties or down in the village, when a client comes to you with the complaints that I've mentioned earlier, and maybe you have treated this client for quite a while, and they're not going off.
Yes.
You should now begin to have in mind, could I be dealing with cancer? Because they present most like any other disease. So when it comes to investigations, there are so many, and we have here in the country.
Yes.
We have chest X-ray. We started just with the basic chest X-ray. It will be able to show a tumor, maybe in the lungs. You can go to a CT scan or MRI, which will be able to show you also a tumor in the lung. Then also we have what we call PET scan. A PET scan is more detailed. It will be able to show even cancer. It's very early or infancy stage. Also, PET scan is currently present in this country. Also, you can also do a bronchoscopy. Now, bronchoscopy, when you do it, you have to get a tumor from the lung, from the affected side after I've done the CT scan, and it has shown the tumor is in a particular lung, particular lobe. Now you can do a bronchoscopy to get the tumor. Now you take it for histology to the lab, whereby the doctor in the lab will be able to interpret it and come with a diagnosis of which type of cancer you are dealing with in the lung. Is it small cell lung cancer? Is it non-small cell? Or sometimes you find it's mixed.
Yes.
It has both cells.
Yes. So how do you go about it?
Once you have diagnosed the client,
Yes.
it doesn't mean it's the end of it. As we talk about cancer, it's not a death sentence.
Yes.
The earlier you detect it, as my colleague has said, the better or the good the prognosis is. Because when it comes to cancer, or to cancer treatment, we talk about three things. We talk about curing it, controlling it, or palliating it. So the earlier you find it, the better you talk about curing the disease. When it comes to stages 2, 3, 4, you're talking about controlling it. When you come to stage 3, towards the end, at stage 4, you're talking about palliating it. You're not curing it, you're not controlling it, you're palliating it. So when it comes to treatment for cancer, the number one treatment for cancer when it's very early is surgery. And the outcome is very good.
Yes.
So the surgery, depending on the extent of the tumor, there's removing of either one lobe or all of the lobes. When I started earlier, I talked about the right side having 3 lobes and the left side having 2 lobes. So depending with which part is affected and also with the extent of the tumor, the lobe can be removed, the lung can remove the whole of it. So you find somebody can survive on one lung. So also the other form of treatment that we have in lung cancer, we have radiotherapy, towards which is localized towards the tumor. It's just in radiotherapy, when I talk about radiotherapy, it's about using radiation, which are highly energized X-rays towards the tumor to destroy the cancer cells. But it's localized only towards that specific tumor.
Yes.
Now, when you talk about the other form of treatment, we have chemotherapy. But now chemotherapy is systemic, whereby the chemotherapy is administered, the cytotoxic drug, which is used to destroy the cancer cell, is administered intravenously via a vein, which will be established and infused into the patient, of which it will be now systematic, it will go into the whole body. Because in cancer, we normally talk about metastases.
Yes.
In metastases of the disease, we have what we call micro. They are small. Cancer has the capability of moving from one point to another.
Yes.
So when you use chemotherapy, you are able to destroy those cancer cells, which are very small, which are trying to spread to other body parts. Then the other form of treatment that we have that's latest on lung cancer, we have what we call the targeted therapy. In targeted therapy, we have the specific treatment going to specifically just to that tumor and destroying those cancer cells.
Wow, thank you so much for that description of management. And before we go for break, we want to hear about adolescent in 1 minute and what you do to ensure that they know that they are also in danger.
So viewers, once again, this is a good opportunity and a wake-up call to all of us in the society, to the young minds who get influenced by seeing the hot pictures of people who are smoking. The danger does not manifest today. When you start smoking today, the danger is not going to be with you today. It is going to come to you later on in life.
Yes.
And to the adults who are still smoking, I'd really like to urge you to change your ways, because every time we talk about cancer, lung cancer is the most affected by smoking, but all the other cancers, the element of smoking is always part of it. So let us pick up our thoughts and let us quit the habits that predispose us to the diseases that we are talking about. But in the same light, I would like to say that even if there is cancer in the family, even if there is lung cancer in the family, that is not the time to tell the person suffering that we told you to stop smoking. Now you didn't stop. No, that is the time to support the patient, work with them, take good care of them, and ensure that they get to recovery.
Wow. Thank you so much, Margaret and Ben. That was discussion about lung cancer, and this is Health Talk, whereby we bring it into your house as you are in your workplace. Keep it tuned. We shall continue after the break.
This is our world, our country, our community, and our society. It's all happening at Chungu cha Jamii. In this place, we talk about parenting, we talk about marriage, we talk about relationships, we talk about dating. We go to the prisons and find out how life is over there. We talk about the village, what happens down there in our slums. What exactly is happening back in our schools? What is happening with the people that we know as our husbands and our brothers? What is happening with addiction also in our society? We offer solutions. We bring in experts, we bring in psychologists to tell us more on how to handle our problems. Come, let us share together. Let's get round the pot, have some soup, and talk about the issues in our community.
Hello. Welcome to the GBS article, where entertainment meets enlightenment and creativity meets exposure. Join us on the most interactive art club in all of Africa. This is the Art Club with Benzi. See you there.
Hello viewer, welcome again. We are still on Earth Talk, whereby we are bringing it to you into your house, into your place of work. And today we are requesting men to visit their their clinics, their hospitals, whereby they will be able to be tested for lung cancer. We are advocating for men kindly to do away with smoking. If you have already started, there is a strategy you can stop. We are advocating that if you have to smoke, be in a private place, because that smoke can be inhaled by another person who can also be able to contract the cancer or any other respiratory disease. We have seen patients being diagnosed with lung cancer. We have seen patients undergoing the treatment of lung cancer. We have seen the relatives of those patients. But today, we would like to understand what is this journey that we are going to walk with them. And for this journey to be complete, in the house I have guests with me, and I would like them to introduce themselves as we go through the journey with lung cancer. The lady first, welcome to the show. Kindly introduce yourself.
Thank you, Lucy, for such an opportunity. My name is Joyce Ngie. I'm a palliative care nurse, where palliative care is an approach that we give quality of life. Despite having been diagnosed with the cancer, we walk a journey with you to ensure you have quality of life, ensure that we walk a journey with the patient and even the relatives. Many are the times that, especially when one is diagnosed with lung cancer, most of them, they get so much upset, distressed, and they just conclude that it is over. But when we come in, we show them it is not yet over, because there is no at one given time. In palliative care, we say that there is nothing we can do, because we'll have to manage symptoms that arise. We manage where there is need for physical treatment for pain. We make sure that we avail those drugs. Where we have to manage the psychological, the spiritual, the emotional, we make sure that all those symptoms are managed, and both for the patient and also for the caregivers or the relatives. Most of the times, the family members sometimes can be forgotten, but we make sure that most of the time we get a family conference with them. We create awareness about maybe the kind of the cancer the person has been diagnosed with. We make sure that we help the family to cope with the disease. We help the family to understand the magnitude. to understand what are the signs and symptoms, to understand the side effects of even the treatments that are given, such that we are able to help them even to ease those symptoms and ensure quality of life of the patient and the families.
Thank you so much, Lucy. My name is Micah Langat. I work with Kenya Institute of Professional Counseling, also known as KIPC. At KIPC,
Where is it located?
We are located, of course, we have a satellite of major campuses in Nairobi, which is the main campus. We are located at the beautiful suburbs of Nairobi Central Business District, few park towers, 7th floor.
Okay.
Yes, it's at uptown.
Okay.
Yes, so at KIBC, we train counselors and psychologists taking career interest in those areas, helping profession, we could generally say that. So as part of that as well, we have a functional department where we have counselors and psychologists.
Wow, thank you for that. We have been discussing about diagnosis of cancer, treatment of cancer, and all the management that comes with it. We have our key element, who is the patient. But this patient is not working alone. This patient is not staying alone. This patient is not worshiping alone. So there is that broad network of a thing. But today, I would like Langat to take us through the process of this, the psychological torture, the denials, the many questions, the doubts that the patient is going through, specifically for the patient. For example, in the management, we've heard very clearly from our panelists that there is a possibility that your lungs, one of your lung may be removed, or part of that lung. And we know the function of a lung. How is it for the patient, and where do you come in?
All right, this is very interesting because I am actually having a first-hand experience of that. We were having our old man. Our old man was suspected of the same, our grandpa. So being a caregiver, yes, so it's a first-hand experience. So actually know exactly what was going on and what it came out like. So when our whole man was suspected of lung cancer, first of all, trying to persuade him to go for tests.
Surgery.
Yeah, first of all, one of the things that come out, and because lung cancer is associated with age, again, it's something that comes almost later in life, so you'll associate it mostly with people over 40 years or by greater percentage. So that is exactly the nature of the people. The population is someone who is already elderly, and when that happens, so first of all, they have reached a stage in life where they think that it's their time to go, right? So one of the things that come out is resistance. So from
the medical care or anything to do with
they do not want
hospital.
They do not want to go to the hospital. So one of the things that we do as counselors and psychologists is to prepare them to know that this is something that they could have a fruitful life in their late life, still able to impact on people and do what they love in that late life. And so one of the things you like to remind them is that they are loved. And why we like them to go for treatment is because they still can, they still have wonderful people around them that they would love to be with them. So resistance, or working with them so that they can conquer resistance, is first of all explain to them that this is something, a normal thing to them, that is going to be part of life, especially as part of old age. So that is what we do with them, preparing their mind, and especially we like to hear what they are going through. You like them to describe what is happening in their body. So even before they meet a medical practitioner, you like them to describe to you what's going on, what's going on in their body. Yes.
Wow. I'm so sorry for that you had to go through it, but this is why you are a hero, to encourage others. And my question is, did he later accept from the counseling? Was the counseling successful?
Yes, it was, because after seeing that very many people are of the same opinion that we could call for this, he later accepted. Resistance was still persistent, although we were able to work to reduce, so by a greater magnitude, it decreased, because even after being given medicine, I mean, there were multiple medicine, of course, some to be, some you puff, others you take, and injections, and all of them, and I could see the way
the drug burden.
Yeah, the drug
burden of the medicines.
Yes. Of course, we were very quick to assure him about the financial, telling him that, of course, we were going to be taking care of that. That at least reduced his anxiety, because, of course, they also care so much about finances. So my man was so much concerned about that, because I remember one of the questions he was saying, well, you know, cancer is a very expensive kind of journey. How will we do that? So we were very quick to tell him that it's going to be possible, because we were going to be taking care of that.
Wow.
So that assurance at least reduced anxieties, financial anxiety, and so it turned out that when we were able to offer him social support, then he realizes that, of course, this is something I could do, because we were able to offer him rides to the place, and something that he felt good about, and actually talked about it.
Wow.
So yes, so it's possible.
That was very wonderful experience, and it's an eye-opener that social support is very important to explain to the patient about everything that they want to know, not to do things as if we are hiding anything from them. And I understand this is why the old man was able to accept the care, which means then there are people who are unable to get psychologists or people to walk the journey with them, and it is usually very hard for them. And this is where, Joyce, you come in. Now this was the patient. What about the caregivers? What about the family, the relatives? Yes, they are really, really encouraging the old man. Do they really need help? And where do you come in this? Welcome.
Thank you, Lucy, once again. I would like to say that in palliative care, we normally say, break the bad news well, and you'll be remembered.
Break the bad news well.
You'll be remembered.
Seriously, Joyce? This
break
is a
the bad news badly, you will never be forgotten.
Break bad news well.
And
so this is a bad news you're about to break.
Yes.
Then you have to do it well.
You have to do it well. Doing it well, you have to start by, first of all, you inquire what they know and what they don't know. They are always, it is, let's say the patient and the families are always very, very, very genuine. They will tell you what they know. They will tell you what they don't know. So from that background, then you are able to take them one step at a time.
Okay.
You don't speak with the jungle words. Maybe you start telling them about medical terminologies
or
which they cannot.
You just say, yes, cancer, kindly go to that room.
You see now.
And instead of going, they stand and stare at you like, what are you saying? What do you mean?
Yeah.
And some will even keep quiet, which means the bad news has been broken badly.
Yes, they will be in shock for long, and that will hinder the breakthrough of the family members' understanding about their patient, maybe understanding where they are supposed to come in support. So when they get that perspective of what their loved one is suffering from well, then they are able to support the patient. They are able to come in and help. Like my colleague has said, when they did explain to the patient about the disease and how it can be treated, the outcomes, the burden that it is there, you have to be very open and explain to them everything, including the financial burden, and also help them to make informed choices, decisions.
Wow.
If it is money, how they can be able to get. Like when we talk of NHIF, some people don't know that NHIF is very important.
So you're saying NHIF can be able to cater some amount in cancer treatment or everything? And which kind of contributors of NHIF? Is it the permanent and pensionable, or even the self, I don't know how we call them, those who go pay on the counter?
Yeah, even the self, as long as you are paying, the lowest nowadays is 500. So as long as you are contributing 500, we have many hospitals that are able to cater for those bills, maybe for chemotherapy, for radiotherapy, like when we talk of Kenyatta National Hospital, even Texas Cancer Center, Nairobi West, most of these private hospitals nowadays, they are catering for cancer treatment, as long as you are paying as low as 500 per month, which is very affordable to many families. And you find most people don't know until you explain to them, and when they get the understanding, they are able to start paying, and then they are going to be relieved the burden. So the question of how it becomes answered. The others, it is the anxieties that come and distress out of breaking those bad news badly. Some of the caregivers will tell you kindly, we don't want our papa to know. They don't want their loved one to know what they are suffering from. But when you go step by step and explain what it is and what it means for the patient to understand what he or she is suffering from, then they are able to be positive, and then they accept, and then the patient is able to at least walk the journey together with the family members. Because for instance, like the patient Langat was dealing with, if we didn't know what he's suffering from, how do you convince him to take, maybe to start treatment of a disease he doesn't know? So, and you know, honesty is very key when we are dealing with the people who are suffering from cancer. First of all, you have to develop a trust relationship with them. They can only get that trust if they find that what you are telling them is the truth. But once they realize they are lies, then they'll keep off and they'll never. So when it comes to the caregivers, you know, they also get worked up. Some of them, they get so much distress. This is somebody who was a breadwinner. They are wondering how is life going to be. There are children there to go to school. Maybe this is a person who has been paying school fees. There are so many complex issues that one has to deal with. So we have been working a journey with these people. We try to do a lot of counseling. We try to do a lot of supportive counseling. We also call them together with the others who have been working that journey, to that journey of cancer treatment. So when they come together and maybe they hear a testimony from somebody who was suffering from the same cancer and now has already stabilized and is doing well, then they are also able to be positive, and they are able to at least walk that journey easily, rather than when they just get isolated and they remain alone. So we do a lot of consultative, we do a lot of home visit. When we get there, we get to understand maybe even the level of that family. How do they operate? Who are the primary caregiver? Because we have to identify the primary caregivers, secondary caregivers. You can even use even friends if there are no relatives who are available. So we do a lot of a lot of consulting here and there, and ensure that at the end of it all, the patient and the family, they are all getting quality of life. They are not suffering. They are not dying inside, because most of them, they start dying inside once they are told now this is lung cancer. You know, from the research, most of them, they know that once you are diagnosed with maybe cancer of lungs, the lifespan is so short. They don't have the awareness. That is only because most of them are diagnosed late. But when you help them to get the real staging at early stage, then they are able to understand it is not a death sentence. They can be treated and then they get well, or they can get support until their loved one, maybe we at one given time, the time of dying comes, he'll have a dignity or a dignified death.
Wow, thank you, Joyce, for walking with us this journey. In fact, I was feeling like I'm already doing the home visit, like we are talking to them. That was very wonderful. And this is Health Talk, whereby we are bringing it to you, our viewer. And we have come to a time, according to Joyce, our palliative care nurse all the way from Kangundo, whereby we have done everything. The doctors have removed even that lung through surgery, all the chemotherapy, and it has all failed. All the prayers, everything. And now a time has come whereby we have to give what they call in quotes now the real palliative care. You want to see the last days of this patient. You have to explain. The relatives are curious. They want to hear. Langat, what are you going to give us the exact words you will talk to the patient? As Joyce tells us what we will tell to the caregivers and the relatives and family.
Thank you. Alluding to what Joyce said, that it matters a lot how you say, as much as also what you're saying matters. Like, it means a lot how you say. Mm-hmm. Because I was actually...
Bad news broken well.
Yeah, bad news broken well will
Yes.
be remembered.
Mm-hmm.
Yes. So it matters also, how you say. So I remember a story I was given. Actually, this was an actual therapy situation. And so the client was coming to me telling me that I was required to break news to someone who was sick, right? That this is a situation that has gotten worse. It was on the almost full blown. And so now the nurse was supposed to break this to the patient, and then and right there she didn't have the exact words. So she told me she went there, and then she started by saying that there is a situation. There is a situation in your lung that is developing. Of course, trying to cover up the situation and taking the client rounds and rounds. So the client was anxious and she wanted to know what is happening. So of course, he went straight to the point and told the client that I think you have cancer. So the client says, "You think I have cancer?" And of course shouting, the client shouting with agitation and saying, "So then why are you taking so long to tell me?" And the client went out there raging in bitterness. And that is exactly what you will expect when you tell them about the situation. You will expect them to go into rage with anger and bitterness, and that shock that will come from getting this news. You love to know how to deal with that. You love to know that the client will actually likely to go into anger or even go into an extreme kind of stillness or shock that actually paralyzes them. So some other times you need to know also that at that time when you're breaking the news, you need to understand that this news might actually affect their their impulses and their breathing. So you need to understand the nature of exercises you like to tell them. So before breaking the news, you like to make sure that they are calm and also to them the mindfulness exercise. The mindfulness exercise applies everywhere, because you like first of all to make sure that the state at which you are telling them and the environment is favorable to break the news. So you like first of all to tell. Of course, in psychology you also employ storytelling. So you like to tell them stories that almost bring them home. So it's also a way of creating an atmosphere before you tell them that.
Wow, that is Mika Langat from Kenya Institute of Professional Counseling. Is one of the lecturers, and we had We had Joyce with us, who has taken us the journey through the caregivers and relatives. Once again, viewer, we thank you for being with us from the beginning of the show to the end of the show. Stay tuned for more shows on Health Talk. Bye-bye.